I want to start busting myths. Hypertrophic cardiomyopathy is a rare disease.
It is far from a rare disease. It is rarely diagnosed, but
Yes.
but it is highly prevalent.
An okay resting echo means the patient is okay.
A resting echo without provocation is an inadequate echo. And you really can't call someone non-obstructive until you add on an exercise echo on top of that.
Hypertrophic cardiomyopathy is more common than we thought, more complex than we assumed, and more treatable than ever before.
I don't think we've ever had an abrupt change in how we manage obstruction.
It is my honor to welcome two leaders shaping this new era of care. Cardiomyopathy and sports medicine expert, Dr. Matthew Martinez, and cardiologist and research leader, Dr. Nani Bhalla.
Lots happening in the field right now. Multimodal AI models where you're combining ECG, MRI, echo images. I think that's where all of these things are going to blend in to really get patients identified sooner.
HCM is no longer the disease it was a decade ago. The question is whether our approach has evolved with it. This is DoctoRx Unscripted. Now let's get started.
So welcome to DoctoRx Unscripted. Thank you for joining us. So today, I really want to dig into hypertrophic cardiomyopathy. To me, a disease that is so important, but not diagnosed early enough. But before we do that, I want to get to know you both. I'll start with you, Nani.
Okay.
Cardiology. What
Yes.
made you go into cardiology and then drug development?
Yeah, so cardiology, I would say, it's the perfect mix of all the great sciences, is the way I looked at it. It's biology, biochemistry, physics, math, pressures, volumes, flow. All of that was just absolutely amazing. And those were all my favorite areas when I was studying. So
Physics.
yeah, believe it or not. Actually, that was the most attractive part, was the physics part. So that's kind of what drew me to just the physiology of everything was really what got me to, and hemodynamics, that's what got me to cardiovascular.
And then you decide to take a path into drug development.
Yeah, and I think part of that is, as you all were talking earlier with Tommy, Matt, I think, made a very interesting point. He said, for every problem, there's a solution.
Yeah.
And I think that's what drug development's all about. It's trying to identify those problems, continue to engage with our external thought partners like Matt, and trying to understand what are the problems that we should be solving for, and then really going into that science and designing the right molecules, the right compounds to solve those problems.
Yeah. And what about you, Matt? What made you go into cardiology and then sports medicine and hypertrophic cardiomyopathy?
I think headed into med school, I was a surgeon for sure. Probably an orthopedic surgeon.
People keep thinking they're going to go into surgery.
I think this is, you get your hands dirty, you have gloves on. My wife might tell you that I can tell people what to do. Like I ask for something and I get something delivered to me, scalpel. And they bring it to me. And it just appears out of nowhere. So
we get to fix the problem.
And then I couldn't agree with what Nani said more. For me, this was the story fit the electrocardiogram, fit the physical exam, fit the evaluation, and then fit the treatment. It was the cleanest for me of all the specialties. And it just made sense to me where I could ask a question, we can come up with a way to evaluate it, and then, by goodness, we had lots of options to manage these diseases, whatever the disease was we found. And I met somebody early on in my career that completely changed the trajectory of, where I was headed in medicine, certainly where I was headed in my life, and still to this day is a big mentor for me and is an expert, no surprise, in hypertrophic cardiomyopathy.
Do you want to name who that person is?
People will know, anyone listening who's a cardiologist will know who this is. His name is Rick Nishimura. He is the cardiologist's cardiology.
So now, sports medicine.
Sure.
What made you go into...
Yeah, so I was an athlete my whole life. I played high school sports and college sports.
Which one?
So I played all of the sports, right? Different than now, but I played collegiate baseball, and that was what got me to college and got me through college, and had very still ties to the sport. So I was sure that maybe I would be an orthopedic surgeon, but turned out I didn't really love doing the work of orthopedic surgery.
Is it the hammer? Oh,
That's for a whole other podcast. It felt like an episode of, a carpentry, and it just wasn't a good fit for me in the end. So I pivoted.
So Matt and I were in an airplane together, and there was a passenger who was in the restroom, and suddenly we just hear a bang, and this passenger just falls out of the restroom onto the floor of the airplane. And I was sitting right behind her. So, we come up. There were a bunch of folks who came up. Matt, by the way, just sat there. I said, okay, someone else is taking care of this. It's okay.
I think he's got it. We're good.
And the flight attendant says, what do you do? And says, I'm a hematologist. What do you do? I'm an ED physician. What do you do? I'm a cardiologist. Okay, I'll take the ED physician and the cardiologist. Hematologist, you go sit down.
See? It's true. Do they have a blood disorder? Do they have anything happen in the marrow? Anything happen in lymph nodes? Anything happening in any tumors? No, then.
So, I will tell you, my family thinks that I attract this on airplanes.
It is an incredible field.
Yeah.
It is an incredible field.
And think of the growth of the last 50 years. If you look at the history of cardiovascular medicine, other than infectious disease, it may be the leading change maker in medicine in the last 50 years. And by the way, we're still making changes, right? Yeah. And that's what we're talking about today.
And that's what we're talking about today. Yeah. So let's start with hypertrophic cardiomyopathy. Maybe, Nani, you could start just explaining what that is.
Yeah. So, obviously one of the most common inherited disorders from a cardiovascular perspective. And most of the cases, vast majority of the cases are still familial. So it's a genetic inherited disorder with basically an abnormality in sarcomeric proteins. And it's this abnormality which then leads to just this disarray of how the myofibrils get laid. It has to do with then just interstitial fibrosis. And all of that sets up this milieu, which is electrical instability, a hypertrophied, thickened heart, and unfortunately, these areas of fibrosis, which then also lead to diastolic heart failure, diastolic dysfunction. And with the hypertrophy, and a lot of the patients have mitral valve issues, and with that mitral valve issue and a hypertrophied septum, mostly in these cases, or posterior wall, you get this gradient across, which I know you guys were talking about earlier as well, and there's this outflow tract gradient in the obstructive form. And then there are obviously a lot of folks who have a non-obstructive form as well. But in the end, the issue is this whole myocardial disarray and interstitial fibrosis and hypertrophy, diastology issues, mitral valve issues, gradients. I mean, it's just a very, very complex coming together of what we talked about earlier, a little bit of physiology, hemodynamics, and the biology of what's happening in the heart. And, we talked about the familial form, and I think, Matt, have you chime in on the genetic side of things, because it's somewhat of a complex thing when you think about the genetics of hypertrophy. It's not the straightforward thing that we think of in cancer and things like that.
It turns out life's complicated, right? Who knew?
Yeah, so genetics, tell us a little bit more about.
So this is a disease that runs in families. That's how I explain it to patients, and we will find clusters of this. Once you find one family member, odds are you're going to find another. This is a disease of normal longevity. Most people do very well with this disease, but we have to, of course, identify it and then treat it. But it is genetic. We typically tell people it's always genetic. The most common ones, genetic markers we think about are MYBPC3 and MYH7. There are others, TNNT2 and TNNI3 are thin filaments as opposed to the thicker filaments of MYBPC and MYH7, and there are more beyond that. This is, the challenge becomes something called variable penetrance. And just because you carry the gene doesn't mean you're going to get the disease. And just because you have the disease doesn't mean we're going to find the gene that's associated in your family. And it's always surprising to me. And overall, we typically say somewhere between 35 and 40% we will find a gene, but the morphology, the distribution of the thickness of the heart muscle determines whether or not we're going to find the gene or not. So this conversation comes up with families because if we identify a gene, they view it as and I view it as, no, this is good. If I can find the gene, I can then search your family, and those who don't have the gene are not going to develop the disease. This is good news. If we don't find the gene, then we're on basically a surveillance fishing expedition for the next 20 plus years, where we're going to do imaging every 3 to 5 years or so to look to see if you ever develop it. So it's an advantage if we can find it, but boy, is it complicated. And we don't understand what turns on the gene, why if you carry the gene do you develop the disease at 16, or why others don't develop it at the age of 50. And then how come we find this so commonly and yet the genes are still negative?
Then tell us a little bit about obstructive versus non-obstructive. Let's start there, and then I want to learn a little bit more about the symptomatic piece of it.
So this is a disease of obstruction. The majority of patients with hypertrophic cardiomyopathy will have obstruction. We typically say about a third will have resting obstruction. Another third requires something to bring out the obstruction, leaving the remaining third to be non-obstructive. So what does that mean? So non-obstructive is when the heart muscle is thick, it is stiff, but when it contracts, it has diminished blood flow from inability to squeeze out blood efficiently. But the mitral valve, which is the doorway between the top chamber and the bottom chamber, it doesn't prevent blood from leaving the heart. So it's really a stiffness problem in non-obstructive HCM. It doesn't relax well.
Right.
In obstructive HCM, the mitral valve is too long. And because the muscle is thick, it points the blood direction initially towards that long leaflet, mostly the anterior leaflet of the mitral valve, and pushes it into the way, preventing blood flow from leaving the heart. So the obstruction comes from the mitral valve leaflets being too long, plus the extra thickness in the majority of cases. And that gets worse with dehydration. It gets worse with faster heart rates. It gets worse with lower blood pressures. So you can see why many times at rest, patients feel fine.
Right.
But when you exert yourself, you get a little dehydrated, walk up a flight of stairs, maybe you do it too quickly, maybe you do it in July. And when that happens, the obstruction gets worse, then you develop all of those symptoms related to hypertrophic cardiomyopathy. So that obstruction is key because the way we treat hypertrophic cardiomyopathy varies based on whether or not you're obstructive or non-obstructive. And the challenge is the symptoms are often not enough to tell you the whole story. So you need imaging to make that definition.
So let's talk about the symptoms. What are the symptoms?
Yeah. Common symptoms, chest pressure, breathlessness, exercise intolerance, inability to participate in life the way you want to. So maybe that's walking across the street. Maybe it's walking up 2 flights of stairs. Maybe it's that I used to be able to jog a mile in 10 minutes, but now I can't do it in 20. So you can still do the mile, but you just do it slower. So the point of that is that people, they lower their expectations by slowly accommodating, which is why this disease is so difficult to make a diagnosis in many patients, because they've learned to live with it. They don't know how good feels anymore. They've been like this for so long. So is their mom. So is their brother. And they've learned to live with being just slower than everybody else.
They've normalized it.
Right. And you heard from Tommy earlier, man, I could compete as a professional athlete at the age of 22 or 23. But when I took away the obstruction, I got better. So later in his career, he should be struggling, but he actually was better than he was early on. So it reminds us just how difficult and how much people tolerate being symptomatic. And those symptoms, by the way, are also really common. They overlap with heart artery blockages, other types of valve disease, good old-fashioned rhythm changes like just atrial fibrillation come with this disease, but they also come with other diseases. So it gets lost in the mix. But what I tell clinicians is if this is so common, 0.2%, 1 in 500, maybe we should be thinking about this first, not after exclusion.
So to your point, it's more common than we realize. So why is it so hard to diagnose?
Well, I think some of what Matt was just saying, the symptoms get misconstrued from both sides. As we were talking, that the patients minimize it because they've kind of evolved in this way, and they, whether they blame it on, hey, I'm getting older, or I'm just not exercising anymore, I'm not doing this, so the symptoms kind of become passé to them a little bit, and then the clinicians, because they are so non-specific, well, maybe you need to go see a lung doctor, maybe this is your asthma, maybe this is this, and so a lot of other testing gets done. So as a result, it becomes, I would love to say it even becomes a diagnosis of exclusion, but sometimes it just becomes a diagnosis that just doesn't even come to mind for a lot of folks, and say, oh, your pulmonary functions were fine, your this was fine, your exam doesn't seem like, because if there's no, like Matt was saying, if they don't have a murmur at rest, and you're not provoking them, even in a good physical exam, you're not going to find it. And hey, your lungs sound clear, your heart sounds good, your pulmonary functions are okay, go exercise more, which may be the wrong thing to do without actually digging into the things a little bit more and making sure, as you guys were talking earlier, to risk stratify them and make sure that they're safe to, and get them back to their activity levels. So I think it's just this combination of things that makes folks just not think about this as often as they should.
Yeah, I think this is spot on. And this will not be a surprise to you. As a result of the non-specific symptoms, women get diagnosed less frequently and later than men do. So they're told, well, you're just a little anxious, or you're just too busy, mom, or it's something else. You're a little, maybe this is just all in your head.
Yes.
Common story in other diseases, and this one too. The challenge I have is that if we make the diagnosis later in women, what happens? And what happens, we know, is that they do worse. We diagnose them later than men do, and as a result, they have worse outcomes. They have higher levels of obstruction when we finally make the diagnosis. Their symptoms are worse. And I think long-term, we're going to find out that if we treated them earlier, there will be a dramatic improvement in how they do long-term. So this is a familiar story. We've heard this story before, but it's a reminder that even in this common condition, we're still missing it, more so in women than men.
So then how do you diagnose hypertrophic cardiomyopathy?
Yeah, so you got to put it all together, right? That's the fun part.
Yes.
So the story fits the electrocardiogram. So the EKG is often abnormal in this condition about 90% of the time, not always, but 90%. The physical exam is critical. So I mentioned earlier, a third requires some sort of provocation, something to bring it out. So you can do this right at the bedside with something called the Valsalva maneuver, or what I was taught by my mentors, the best way to do it is a squat to stand maneuver. So you have them squat, the murmur gets softer. Then you have them stand up, and the murmur will get louder over the 3 to 5 beats after that. It's a bedside clinical diagnosis. And then, of course, we do sometimes the poor man's treadmill, right? I walk them out to the stairwell and I say, let's go up and down the stairs. And I get to the top of the stairs and I listen. But you first have to suspect it, right? You can't do that on everybody. And you suspect it based on the story. And then the physical exam helps you a little closer. The EKG brings you closer still. And then echo, everybody gets an echo. Echo is the mainstay for how we make this diagnosis. So this is an ultrasound of the heart, just like we do for babies or kidneys or anything else. But we, of course, point it towards the heart and we look for the thickness, the valve disease, and the obstruction. We can quantify it based on echo. And then MRI plays a critical role on top of that, a heart MRI to look to better quantify the degree of thickness and look for other features that can help you not only nail the diagnosis, but also clarify some of the risk. And the other challenge of this is that all that is thick is not hypertrophic cardiomyopathy. So you got to tease it out. And again, we go back to the fun part about cardiology. It's, does the story fit? Does the EKG fit what your thickness looks like? And then the MRI tells a large part of the story. There are specific features on cardiac MRI that might point you more towards an amyloid heart or a Fabry cardiomyopathy or a fixed subaortic membrane or hypertrophic cardiomyopathy. But I think the key is first identifying there's a problem.
Right.
And it's thick. Once you find the thick heart, then we got to look for obstruction and what the cause is. So it all fits together. You just have to think about it.
So then here's a patient comes in to a busy cardiology clinic. What is the red flag that a physician needs to hear in order to trigger the suspicion?
So for me, it's all those if I hear about exertional breathlessness, that's changed. If I've heard about a syncopal episode, a passing out episode, we heard that from Tommy earlier, and we hear it from others too. Doc, I feel fine unless I run up the stairs really quickly, and when I get to the top, I sometimes feel like I'm going down. Chest pressure with exertion, and we should definitely rule out heart artery disease. We should definitely rule out other things too. But HCM has to be on that early diagnostic list. And then earlier patients, less than 20, less than 30, when I'm hearing chest pressure, breathlessness, passing out, I'm still thinking hypertrophic cardiomyopathy first. It's unlikely to develop heart artery disease in that scenario. So those are the red flags for me. And then family story, right? Most of us don't know our family history very well. We don't talk about this anymore. My dad once said to me, we have hardening of the arteries in my family. And I said, great, which ones? And he said, what do you mean? I said, well, there's lots of arteries, Dad.
Yes.
Which arteries are the ones that are clogging? So we had, I kind of dove into that. And so learning your family history is a great place to start, but it isn't always, enough. Sometimes we don't know it.
I mean, I'll tell you, my father said, oh, we have heart problems.
Yeah.
Full stop. I was like,
and that's exactly it, Tania,
What's that mean?
because so I agree with Matt on the red flags. This dizziness at exertion or just nearly passing out. I mean, those should prompt a lot of red flags in someone's mind. But this family history that Matt mentioned, and you just talked about, hey, well, we have heart problems in our or my dad had a heart attack at a young age. And that automatically, at least for me, prompts a lot of other questions. Well, when you say heart attack, tell me what you mean. And a lot of times you may find out that it was dying suddenly, but depending on when it was diagnosed, where it was diagnosed, it was like, yeah, you know what, it was a heart attack. Because that's just the common way that people will just describe an event where someone succumbs to.
Agreed.
And at the end of the day, you gotta ask a few more questions, especially if they were in their younger age or had issues before they had this heart attack and then unfortunately died from it. You have to ask those questions. And it's amazing when you ask those questions. And as Matt said about the heart and arteries, you said the heart problems, you gotta dig into those things. Yeah. And it doesn't take a long time. It's a few good questions, and probably in 5 to 7, 8 minutes, you can get a pretty good sense of whether you're on that track or you're not on that track.
So then, if you look now over the last couple of years, we've seen an improvement in morbidity, quality of life. We heard from Tommy, he's able to play again. Yeah. How has treatment evolved over the last couple of years, and how do you make a decision on what's the best treatment for your particular patient?
Yeah.
Do you want to start?
Yeah. So if we focus just on obstructive HCM, right? Because there's lots of other things that have changed. And this disease isn't only about obstructive HCM, family history, and of course, risk for sudden death and need for defibrillators and atrial fibrillation. But when it relates to obstructive HCM, I don't think we've ever had an abrupt change in how we manage obstruction like we've had in the last 4 or 5 years or so. And that results entirely from myosin inhibitors.
Right.
And so the way we approach it is the same way I approached it before. I just have another tool. So I will say to the patient, these are your options. You have obstruction, you have symptoms. I think they're limiting you. I think you'll feel better if we improve the obstruction. Here are our options. We have a medicine. These are the different medicines we use. These are the ones we've used for years. We don't have a lot of data to support those older drugs, but this is, by the way, what we've done for 40 years without a lot of clinical trials to support it. Simple things, beta blockers, calcium channel blockers, a drug called disopyramide, that they don't have a lot of data to support it, but that is how we've used them for the last 30 or 40 years. By lowering the heart rate, you improve the time for the heart to fill, and then as a result, you improve the amount of blood leaving the heart. So you don't really adjust the obstruction, but you do improve the symptoms, placebo or not. Some people feel better on those medicines. Then I offer them the interventions, right? We offer them an alcohol septal ablation, which is a kind of a unique technique done without having to open up the chest, where we identify the thickness and the blood supply to that thickness, and then we inject alcohol to shrink it. So that's an option for many folks, but the tried and true way we've done this for 40 years is open heart surgery, where we remove that extra thickness, shave it off, as it were. Often we trim the mitral valve, called plication of the mitral valve, and then open up that tract so that the obstruction no longer occurs. And now we have a new tool. So myosin inhibitors are the first specific treatment for obstruction. And it does it very well. And in majority of cases, it does it in a surgical way, getting those numbers, the reduction of the gradient, down into the normal range of 10 to 20, which is the goal of surgery. And the goal should be of the therapy to do the same thing. And it's also affecting the entire muscle. It's shrinking the muscle. The left atrial size gets better. In a large portion of patients, somewhere between 30 and 50%, the electrocardiogram, which was dramatically abnormal before, it normalizes. And it normalizes to a way that even AI can't tell that it's still hypertrophic cardiomyopathy.
Really?
So dramatic.
Right.
And I think, Matt, you brought up a point about earlier on when you're talking about majority of the patients do well.
Right.
But when we talk about doing well, meaning that they don't necessarily die from it, doesn't mean they don't become symptomatic from it. And I think that's part of the other thing as we start to go into, and I think this has been one of those things that, well, this is a low mortality disease. Well, yes, but low mortality doesn't mean that it's not a disease that causes a major morbidity and progression in your life, keeping you from doing the things you want to do, et cetera. So I think some of this coming of age with myosin inhibitors is not just all about, hey, am I going to save someone from dying, but it's all about, hey, can I improve their life, get them more functional, get them back to where they used to be. And going to our earlier points, many patients don't know how good they felt because they've just accommodated it. And when they go on a medication like this, they kind of say, I didn't realize how bad I was really feeling.
Right, because I accepted that as my new normal. Yeah.
This is an important add-on because downplaying the morbidity related with this doesn't serve the patients either, right? So I think it's important to recognize that we're not talking about mortality anymore. Now we're talking about feeling as well as you can for as long as you can. And then for most of us, that's maybe more important. Right? If I can no longer participate in life the way I want to, then this is a dramatic impact, whether I'm alive or not. So this has an impressive improvement in overall symptoms, just like surgery did for years, and surgery still does. But this is now, I think, in front of surgery as a medical therapy option, and we can probably treat people earlier. But I think we're going to see a even further morbidity improvement because we're treating patients earlier in the disease compared to waiting for the point where they say, I am so symptomatic, I'm willing to go through open heart surgery.
Right. So then if you fast forward 5 years from now, where do you see the field going?
Lots happening in the field right now. And I think so now that we have a targeted therapy and we kind of know what the targets are, I think that's the other thing, being able to actually isolate those targets, understand those targets. I think we're going to have better, you can call them myosin modulators, myosin inhibitors, whatever, but they'll be more targeted and they will start to broaden that scope a little bit. And maybe the profile will be a little bit different of these newer agents. And then I think, there's certainly a lot of work going on in gene targeting as well. We talked about some of the causative genes and the majority of these patients. There's some associative genes and trying to sort through that. So I think that's, again, a lot of work is going on in that arena as well. So I think we're going to see a lot of development in that area.
Yeah.
I think you're going to see expansion for diagnosis as well. I'm going to go back.
That's going to be my question to you as well. Like,
so I think,
how do we do that?
I think we're going to see more of that. I think there's a hyper focus, as there should be, on finding patients because this is a contemporary treatable disease. If we find it, we can treat it. And I always tell patients, I worry most about the untreated and the undiagnosed. So the undiagnosed comes first and then the untreated after that. So I think AI is going to play an important role in evaluating.
I was going to ask a question about AI because you cannot have a discussion without bringing up AI. You can't
100%
anymore.
And it's coming.
Yes.
So I think you're going to see it evolve fastest in electrocardiograms because we know 9 out of 10 or more will have an abnormal electrocardiogram. This can be an overwatch. It can be an overwatch in emergency rooms and in primary care and in offices and built into software to say, I wonder if this is HCM. You're still going to need a clinician, right? It's still going to be a probability that this could be hypertrophic cardiomyopathy, but I think ECG will start with it, and then echo is not far behind. Right. There's going to be better and better techniques to use, again, as an overwatch, looking at the echo images as they roll off and alert the clinician. I know the last 3 were normal. This one you should spend a little more time on.
Right.
And I think that's the trouble, is that we see so many patients that distilling and sorting out which of the ones you should spend extra time on and which of the ones get the brief visit, I think AI is going to help with that.
Yeah, that's what I was going to get to as well, Matt. I think that last point that you're going to see where screening might need to be different, or once you have raised a flag on someone who needs to be followed more closely than someone else. I think AI, and I think this will get to, is already starting now, this multimodal AI models where you're combining ECG, MRI, echo images, and then saying, okay, in this multimodal model, here's a patient who flags himself as someone who's going to be more progressive, and maybe that's the one that you follow more closely or differently. I think that's where all of these things are going to blend in to really get patients identified sooner and then hopefully deciding, as Matt was pointing to, which ones do we follow more closely than others. I think there's a whole world that's going to open up with these technologies.
And that's going to be important because you think through a busy clinic. How do you, I mean, that's typical, right?
Yeah.
You have so many patients. How do you get it flagged to make you pause and say, let's go deeper?
Right. Yeah, and even starting, some of these medications that we have, how do we decide whether we start them earlier,
right,
and see whether there's a benefit. We talked about that myocardial disarray and everything, and I don't know, if we start earlier, do we prevent some of that? Does that get better, and can we follow that? You may not see the clinical benefit of that for some time, because again, it's a disease that is variable penetrance, but if you can start to demonstrate that it's impacting those myofibrils are getting laid, I think it could really be something that can be potent down the road. So I think a lot to come in this area, and it's exploding.
Mythbusters. I want to start busting myths.
Okay.
First myth. Let me know if it's a myth or not, first of all. Hypertrophic cardiomyopathy is a rare disease.
Yeah, it is far from a rare disease. It is rarely diagnosed, but
Yes.
but it is highly prevalent. We see it everywhere, and lots of opportunities to improve that. As I've said, 80+%, maybe as much as 90%, we are missing the diagnosis, and that's whether you have symptoms or not. Right? So whether you have symptoms or not, you still fall in about that 10% range. 85 to 90% of the patients are going either misdiagnosed, undiagnosed, right? Or they're just flat out not seeking care. And that is an important next step for us, is not only identifying it, but how do we make sure that there aren't disparities of care, so that no matter where you live,
right,
you get the same level of care.
Right. So next one then. An okay resting echo means the patient is okay.
Myth.
Okay, tell me more.
100% myth. So we see a couple things. One, the echo may miss it. We know that MRI is a better tool to better identify walls that are thicker. So in a highly suspect patient, an MRI should be used, probably underutilized, more so than we even recognize. The utility of MRI, access to quality readers is a challenge. So it is a myth. And you can have no resting obstruction, a mildly hypertrophied ventricle at 15 or 16 millimeters, which is just over the cusp of what we currently call hypertrophic cardiomyopathy. You can have no obstruction at all, and it's often missed, but with provocation, a well-done goal-directed Valsalva, an initiative we've spent the last 2 years trying to distribute around the country and certainly around the world about bringing out the obstruction. So a resting echo without provocation is an inadequate echo. And you really can't call someone non-obstructive until you add on an exercise echo on top of that. And those who are suspect, if they've got symptoms that sound like obstruction, more needs to be done.
Yeah, I think a normal resting echocardiogram is in the eye of the beholder. And that's where if the story is really good and the echo is, then I want to do more with that echo. So that's where, and then the MR. So to me, this, and unfortunately, in a lot of our practices, even when I was in practice, you would get a patient referred, but they would get the echo before you actually saw them. Right. So a lot of times the echo was already there, or the echo would be sent to you, and it would say, normal echo or whatever, and then you'd hear the story and you'd say, well, hang on, this doesn't make sense. But I think part of that is that in a busy practice, a lot of these tests are actually done before the patient actually comes and sees you. Right. And you can't let the results of that test bias how you're going to talk to that patient and the conclusions you're going to make.
Fact or myth? After diagnosis of hypertrophic cardiomyopathy, you have to now slow down your sports. You can't continue life as
Matt's the one to answer that one.
Yes, especially for those who play rigorous sports.
Yeah, so if the days of uniform disqualification are over. So that change in practice has been about 5 years in coming. Lots of guideline changes, lots of work into this, but still more work to be done. We're not done sort of sorting through all that. It still requires risk stratification. It still requires an individual assessment. It still requires expert interpretation of those images. And as Nani mentioned, the echo interpretation, the MRI interpretation can be quite variable. So this myth that you are done, that you are no longer allowed to participate in anything, that life is over as you know it. I've seen those phrases. Maybe you should pick up knitting.
Right. Oh my gosh.
We're going to eliminate all
my
that,
gosh.
right? Those days are over. And they should be, because we know that if you don't exercise, whether you're on a professional field or not, you do worse. Fitness is the strongest predictor for outcomes in cardiovascular health, including hypertrophic cardiomyopathy. So this is an opportunity to improve the wellness of individuals with HCM, but they need a risk stratification. We actually wrote an exercise prescription plan for folks. It's free. And we wrote it so that it's free online through the American College of Cardiology, where you can help guide the conversation about what types of exercise you can do, safety, and allows patients to really understand this in sort of normal language. And then if you look at diagnosis, and I don't want to harp on this too much, but if you look at many of the algorithms for abnormalities, it is mostly done on non-African American individuals. So if we're using criteria that says 3 times more likely to be abnormal in one group versus another, we're creating disparities. So we have to have an opportunity to change that as well.
So talking about disparities, how do we equalize it? How do we decrease the gap?
I think we have to leverage technology. We haven't done a great job of leveraging things like telehealth. The ability to get an ECG or an echo that is sent to you more rapidly for review, I think is also a next frontier. So that's where clinical cardiologists partner with centers of excellence to create a wheel and spoke model so that there is an opportunity to escalate the care, even if it's briefly, and then send them back and say, you're fine, come back in 3 years if you have symptoms.
Yeah, no, I think, we talked about disparities earlier, and I think also as we think about technologies, for example, and making sure that our models and these technologies are also trained properly, so we're accounting for that, because, we can certainly train AI models to create disparities as well. So we just have to make sure that we are doing a good job with the technologies that we're training to be trained amongst all individuals who have the problem, no matter what the ethnicity, background, et cetera, to make sure that the predictability of these models, as we get broader into these, is appropriate.
Now, are there any other myths that I need to mention? I don't know if there's any other myths we need to bust.
I think that the last myth that I want to add on is that the story for HCM is over, right? That we figured it all out. Right. And you've heard experts in the last 4 or 5 years say that. Well, everything's been sorted out. Yeah. We have all the pieces to the puzzle, but we know better than that. Right. We know we have to better risk stratify. We have to get a better handle on who's at higher risk and how do we best get them an ICD if they're at increased risk. How do we make sure that the therapies match the patient, and how do we make sure that the therapies are either not cost prohibitive or geographically prohibitive?
So then, in that case, where do you think what is the biggest challenge for HCM?
I think HCM as a whole, there are virtually no therapies, effective therapies, for non-obstructive hypertrophic cardiomyopathy. So we've got some work to do. And it's a different disease. I think part of it is that we get to them so late because we're calling them run-of-the-mill HFpEF or hypertensive heart disease, or we're just missing it entirely and telling them that they're obese or some other reason why they're breathless. So I think that's a huge unmet need that I know that we're all trying to attack and trying to come up with good therapies and continue to work on that. I think I mentioned risk stratification and really getting a better handle on that. And I also think atrial fibrillation is an enormous unmet need. And it may be that atrial fibrillation is just the fever, right? This is the outcome of an untreated obstructive or non-obstructive HCM, and terrific. But treating atrial fib earlier, having better therapies for it, we know leads to better outcomes. And it's part of the morbidity. So we didn't talk about the morbidity of stroke, which is uniquely elevated in hypertrophic cardiomyopathy. So if you have HCM and you have symptomatic atrial fibrillation, you've already bought yourself anticoagulation because the risk of stroke is so high. So we have to find better ways to identify atrial fib, monitoring it in a more easy way, and then, of course, better treatments that are more sustained.
So let's now move into lifestyle modification.
Yeah.
So earlier you spoke about hydration, but in general, when we think about hypertrophic cardiomyopathy in general, what are the lifestyle modifications you tend to advise patients on?
First and foremost, there's some easy things, right?
Yes.
We know that mild to moderate exercise is an important way to improve cardiovascular fitness, mental health, obesity, all those things that go with life in general. So that's important. Hydration's critical. And I usually tell people somewhere between 80 and 100 ounces a day of water. So a lot. And unlike other forms of heart failure where we tell folks to restrict.
Right, because usually that's what I usually do.
It's a different story. And we're
Yes.
saying actually we want you to hydrate more. So if you have extra symptoms, if you feel funny, if you're feeling like a little extra chest pressure on a day that you normally wouldn't, the first thing I say to them is tell me what the caffeine intake for today was. Tell me about how much hydration you had. So that's key.
So if you go and just Google heart failure, you probably hear, hey, don't drink a lot of water.
Exactly.
So,
Exactly.
and then, you got a doctor who's telling you, hey, hang on, I need you to stay. And
hydrated,
solving
yes.
those paradoxes for them as to when they go to the web or talk to, other folks who may have reduced ejection fraction heart failure where fluid dynamics are very different. Sorting all that out for the patient, I think also becomes really important, and for their family and caregivers.
Yeah. And then don't forget about other comorbidities because life gets in the way. We're keeping people alive longer. Good news. But hypertension, hypercholesterolemia, heart artery disease, untreated obstructive sleep apnea, all need to be managed because they are additive. So when I talk to the patients and their family, I give them the 4-pillar talk.
Okay.
The first is symptoms, which we've clearly talked about. Are you obstructive or non-obstructive? The second is rhythm risk. Do you have atrial fibrillation? Do you have VT? A rhythm from either the top chamber, atrial fibrillation, or a rhythm from the bottom chamber, ventricular tachycardia. Then the third is the genetics. Tell me about your family story. How are we going to evaluate your family? Do you have children? Let's talk about genes. Are you interested in genetic testing? And the fourth is lifestyle modification. How do you handle pregnancy?
Right.
How do you handle exercise?
How do you
So most of the time, ideally,
Textbook unto itself.
ideally you have a conversation early, right?
Yeah.
Where if you have the gene, by the way, there are some ways where we can remove genes and prevent you from passing this on. So you and I need to have that conversation well in advance. That if we find the gene, this has value in other aspects beyond just cascade screening of family members and identifying mimics of HCM. And most of the time, you can deliver without any issue. You can have a child, but it is a 50% risk that you will pass the disease on.
Right.
So you and I need to have that conversation, whether you're a man or a woman.
Right.
And then if you have some features, really high obstruction or higher risk, then we may be having a different conversation about what that risk looks like. That's not for me.
Right.
That's for you to decide with your significant other, how that story is going to be told. That's for you to decide. I'm going to give you the options to try and sort through how safe can we do this, how do we do this, et cetera. And then, of course, high blood pressure and all the things we already mentioned. That's the fourth pillar, lifestyle, pregnancy, and all the other life stressors that get in the way.
For all the physicians, especially the ones with busy practices listening, what message do you want to tell them when it comes to diagnosing and treating hypertrophic cardiomyopathy? I'll start with you, Matt, and then you, Nani.
So I think the first message is that we have better tools to identify this than ever before. And thankfully, we also have better tools to manage this than ever before. So whether you're in primary care, whether you're in an urgent care center, whether you are in an OB practice, there's an opportunity to ask these sorts of questions as the first line of care. The medical home for many folks starts there. The second is for the cardiologist. I wish more of them knew that we were partnering with them. We're not interested in taking over their care, that this is a partnership with them, that we want to work with them because maybe there's a new clinical trial that they don't even know is occurring that I can offer their patient that they never know about because they don't eat and drink and sleep this the way I do all day long. And I think that's the message, is that if we can make a diagnosis, we can treat it, and we want to partner with all of those groups to try and improve this diagnostic capability and the management of folks. And the last is that we don't talk about APPs and the role of a nurse practitioner.
Right.
It's escalating in the care of cardiovascular care. The team sport that's associated with management of HCM, nurse practitioners, PAs, primary care physicians, they're a big part of how we're going to manage this long term. It truly is team sport.
Yeah. And what about you?
Yeah, and I think the red flags that we talked about earlier, from a primary care who's seeing someone in their 20s or 30s or even younger who's complaining of shortness of breath, non-specific symptoms, dizziness, just thinking deeper than just, it's a passing thing, or it's a viral illness or something like that, really kind of going deeper into it and looking at the ECG and really kind of paying attention to family history and things like that. So to me, that's probably the biggest advice is dig deeper. And I think this other part that Matt mentioned a little bit about the fact that treatments have changed as well. Because a lot of times I think the feeling is like, you're kind of already on this stuff. I'm not sure I can do anything more for you. And it's this vicious cycle. If you don't think you have a good treatment for something, you tend not to look for it and tend to follow it along. So that cycle needs to be broken here as well for HCM.
Well, then in that case, for maybe patients diagnosed with HCM, what message do you have for them now?
I think the big message is that you should seek care, right? That if you have these symptoms and you're not getting a satisfactory answer, good clinicians actually encourage you to get a second opinion. There's an opportunity. There are patient advocacy organizations that can help direct you, and you should look to seek someone to help answer those questions for you. If you have some of these red flag symptoms, it's our job to try and go find them. We may not find it. That's okay. It may take longer. Sometimes time is our best ally. But if you're a patient, don't stop. There's an opportunity. You just got to go find it.
You have symptoms. You keep probing.
Exactly.
Until your question is being answered and your doctor hears you. So, what I like to end with is, we know that we don't work in a vacuum, and what we do affects so many people. But is there someone that you're fighting for? Is something you're fighting for? Who are you fighting for?
You want to start?
Yeah, listen, I'll just say that before I came into industry and having managed patients with HCM, there are so many patients who would not have ended up with the procedure, or sometimes, unfortunately, even a complication from a procedure, whether it's bleeding or something like that, would have been avoided because of what we have today. So to me, it's fighting for all those patients, who unfortunately couldn't benefit because they came at a different time in their course of their disease. But I still have had the honor and the pleasure of taking care of many patients in my career, and those are very much ingrained in my head. And basically saying that particular patient might never have been on a table for a procedure if we had had this other opportunity and this option for that patient.
Yeah, and sometimes those cases just really leave an imprint on your heart, and they are the ones that keep us going.
Exactly.
Yeah, so for me, it's always been about the patients. That's the center of everything we do. The science, the education, the advancement of the field is really designed to improve the patient experience. So that's what we're fighting for, is the ability to find them, to treat them, and to manage them. All of the other stuff is just supporting that mission. And I think that's the mission of what doctors do in general.
Yeah. No, thank you for that. And I just, as we wrap up, I want to just, again, thank you guys for coming on this program. And a lot of times we talk about making sure that we're treating the person, not just the disease. And I think hearing from Tommy, hearing from both of you, you really see why that's important. You get to diagnose, you ask the right questions, you're getting the right answers, and you're diagnosing them better, giving them a better quality of life, and really raising the level of exposure to why this is important.
Yeah.
So I just want to thank you. Thank you for the work you're doing in terms of developing the right medicines and making sure we're reaching the right patients, and really, again, shining a light on something that is common but uncommonly diagnosed.
Thanks for the opportunity to be here.
Yeah,
thank you. Thank you.
I had a cardiac surgeon once say to me, listen, today's really busy. Try not to help.
Yes.
I was like, ouch. Ouch.
As one of my dean, who was head chairman of medicine at NYU, Farber, when he was training, and I remember we had a cholecystectomy, so I was the first. So he said, I opened the patient up and looked at the gallbladder, it's just a mess. It's a gangrenous mess. So the attending looked over to him and said, so Saul, what do you want to do next? He said, switch places with you.
These stories, I think it gives us a little bit, make us gutsy, brave,
There's value in the pressure that comes with this
Yes.
with this
There
field.
is.
And you need
There is.
to learn. I'm not suggesting that you get browbeaten and brought up and yelled at, and the old days Grand Rounds was like carnage, right? It was all right. Bring her up.
Yes.
Let's see if we can make her look stupid about it. I don't want that either. I learned a lot from being unprepared
You do.
and feeling foolish,
Yes.
and then saying
You won't do that
I won't
again.
do that again.
Yeah, exactly.
Or like, yeah, no, oh my God, I remember so many
No, I
times.
agree.
I remember, yes.
Yeah.
But you come prepared the next time, and also like you learn how to think 2 o'clock in the morning,
Yes.
right? Like,
Exactly.
That's right. There's value in this for
There's
sure.
what advice would you have for the next, I guess, generation of residents that are interested in coming into this field?
So what I would say is that that you have to remember where it started and try and understand the history of this and why some of the things we've done landed us here. And then remind yourself that it's okay to fail, right? That this is, I think that's something that isn't lost. We're so focused on being perfect that taking a little bit of a risk and doing a research project that's complicated and doing some things a little out of your sweet spot will serve them well. And seeking out complex disease is a good way to move forward. And I think we're always looking, they're often looking for a lifestyle choice. And what I've talked to many of my medical students, they're worried about lifestyle. And I got it too. You have too many kids at home. You probably shouldn't go into cardiology.
I'm sorry, how many kids?
I have 5.
Oh, wow.
So I had 4 before, I had 2 before I was done with med school and then on. But when I was applying to fellowship, I had people tell me, this is probably not a good idea for you. And the answer to that is, you can do hard things, right? And you've just got to choose your battles. You may not be able to do everything, but I think you should pick things with a purpose. Pick a field that drives you and gets you up in the morning and takes you away from that family, because that purpose is what's going to make you good at things, not looking for a way out of work.
Yes.
I think that's
completely
important.
agree. I completely agree. You want to wake up, even those hard days, you go, like, it's worth it because it brings so much joy to you. What about?
I don't know. I mean, I would say, that last part was what I was thinking, that, that it's just, make sure it's something that's within your passion.
Yeah.
Because this is hard work, a lot of hours away from your family, and you want to be in a place where you're actually enjoying what you're doing and contributing to, whether it's a patient life or your own, betterment. But so pick something that really grabs you, because otherwise it should never just become a job.
If you were doing things based on just the next dollar, it becomes, that's
But
right.
no, absolutely. I tell my daughter also, like, when you wake up, you want to be just happy every day. Like, I've chosen, if I had to do it again, I would do the same thing
Agreed.
over again. Right?
With the good and the bad.
With the good and the bad, and they say, another mentor used to say, there's nothing better than doing what you love and getting paid for it.
Yeah.
And I feel
Exactly.
like this is it.